It's a real pleasure to talk with you all today. 20 months ago, I think this talk and its focus would have been very different. I think clearly COVID-19 has changed the lab, and it's also really changed informatics, how a lot of us think about our roles in our hospital systems. I feel like for me personally, one of the key inflection points was in early March 2020. And it was actually an email from your chair, Dr. Baird, with the subject line, something like COVID-19, a letter from the front lines. He was writing to all the path chairs around the country about what was coming our way. And I actually read that email on the ski slope. I was on a ski lift with my kids. And I just, that was the day I can just kind of remember the whole, everything changed. It was really amazing email filled with all this practical advice of things we should be doing to prepare. And I think it was actually really helpful. COVID-19 has really accelerated the need for what I'm going to be talking about today, for the lab to really be embedded in EHR workflows, to have real-time data access, rapidly deployable decision support, and readily available machine learning tools at our disposal to use for real patients in real clinical care, today. So no disclosures. This is actually a picture of our hospital back in 1850. We actually had a lab in the hospital. In the basement of this is the Bullfinch building. We had a lab that did urine testing and some just urine protein, urine glucose, a little bit of microscopy. This building across the street is Harvard Medical School, which was across the street from the hospital for about 40 or 50 years in the 1800s. And the medical students were actually the people that ran the tests. They were actually in the lab running tests for us. So fast forward from this Bullfinch building in 1850 to 2001. This is actually when I started on faculty at Mass General. We still have the Bullfinch building. This tent that was here in 2001 is now our vaccine tent, of course, where everyone goes to get their boosters and their vaccines. Our lab has moved a little bit. We're not here anymore. We're up on the 5th floor, overlooking, and that's where I am right now. But even in 2001, our focus was really within the lab. I really felt like when I got there, our focus was completely within the lab. And this was exemplified by the fact that we still had paper requisitions 20 years ago. So as the low person on the totem pole, so to speak, or the new guy on the block, I was often assigned to track down providers when we had oddball things on requisitions. So this was one requisition. This is our decision support circa 2001. So the clinician wrote in, because we had a piece of paper, 3 antibodies for celiac, sprue, antigliadin, transglutaminase, one other, I can't remember the name. So my job was to contact the provider, give them a spiel about what we're testing for now for celiac, sprue, encourage them to use our diagnostic cascade that we just developed, and probably apologize for the fact that we're still using paper in the year 2001. So the provider got taken care of, that all was working fine. And that would work okay in a small hospital or a very small laboratory, but none of us really belong to small hospitals or small laboratories anymore. We're part of big healthcare systems that have big vendor-provided electronic health records. So for us, for Mass General Brigham, we're now 12 hospitals. We're spread across New England. We have lots of ambulatory care centers, rehab centers. We have places up in New Hampshire, way out in the Berkshires, way out on Cape Cod and the islands. And we have to support all of these patients and providers with the same level of care that we gave to our providers when we had a single hospital. So a lot of people, I think, can pine for the good old days when you could see everybody in the cafeteria and talk with them then. But I always like this quote, nothing is more responsible for the good old days than a bad memory. Because when the good old days back in 2001, we really couldn't intervene in care pathways very easily. We had a limited ability to interact with provider orders, assess outcomes. Getting data for quality improvement or a research study that involved clinical data was always a huge hurdle, and so projects just didn't get done. And then there was a very poor infrastructure in place for decision support if it was there at all. And the computational techniques that I'm going to talk to you about today were really not widely used in pathology at all. So if we look at where we're going, we're trying to get to Emerald City. I'd like to use the Wizard of Oz analogy, where we can really provide a deep level of insight, decision support, and really help lead providers down the right pathway in terms of test ordering and understanding what results need. However, we have to start with data. We have to start back in Munchkin land. We can't start right on the outskirts of Emerald City. We have to figure out, how do we get this data, and how do we get it in real time, and is it good data, and can we use this data to drive decisions, and we're going to need to manage it. So we're going to start with data. So where is data? Of course, data is in our lab systems. It's in our electronic health record, but it's all over the place. We have to really understand our system. We have Epic, and we have to understand the difference between Chronicles, the reporting Strato. We have 2 other data lakes, Clarity, lots of different places to potentially get data, and lots of different methods to get data. In addition to the EHR, we still have some legacy LISs. We have an APLIS, a CPLIS, blood bank, HLA, molecular limbs that we built ourselves. And all of these have important pieces of data that we need to run our operation and to provide clinical care. So what we've used is a data visualization tool called Apache Superset. This is kind of an open source tool that was pioneered by the people who did Airbnb to manage Airbnbs. But it's a wonderful data visualization and data access tool. And we utilize it to connect to all of these different data sources, to pull this data into places that our lab directors can actually use it. Put it into self-service dashboards, other databases and reporting tools, tie it to our studio so we can tie it to the analytics that we want to use, tie it to Tableau since that's our enterprise preferred dashboard tool, and really make this data come alive. Once you, the sad thing though, is once you get this data, you realize how bad it is. You pull the data out of your EHR and you're shocked at how bad it is. So all data is not created equal. In order for you to be able to do facile, quick, useful decision support, you have to have a plan to manage and curate laboratory data. And this, I think, is the blocking and tackling, or the plumbing, whatever your analogy you want to use, of lab decision support. You got to spend time on the basics. And this is things like managing things like LOINC codes, base and common names, the categorization of tests in your EHR, all the things that are going to influence whether you can create decision support that's meaningful across your enterprise. So, the snore-inducing, when I lecture to CP residents about LOINC codes and SNOMED codes, I always try to give actual examples of where not having the right LOINC code, actually could lead to a bad outcome. Because the lab build is really an essential driver. It drives a lot of the clinical views in the EHR, so results review, flow sheets, trending, and key EHR functions. If you want to write a report, if you want to do health maintenance, if you want to have good alerts and rules and good decision support, you have to pay attention to the laboratory build. In addition, with Happy Together, which is Epic's tool for sharing data, almost every site now interacts with many other sites. We exchange data with almost every hospital in New England now. And so if we're going to do that, we have to have standardized and accurate LOINC codes to use FHIR servicers or the clinical data architecture. However, this sounds like, okay, just clean up the lab build. What's the big deal? Put an analyst on it for a few days or a few weeks and you'll have it cleaned up. However, the typical lab build has about 50,000 orders in it and about 300,000 different result components that need to be actively managed. So we have a very big task. What we've turned to at Mass General Brigham is software from a company called Clinical Architecture. They're right outside the LOINC headquarters in Indiana somewhere. But the mantra that we have is, if for lab data to be useful, it has to be interoperable. You have to be able to use it throughout your organization. normalized. You can't have 10 different ways to say CBC, and actively manage. And actively manage because data changes on a week-to-week basis. We decide to interface with another trading partner, or one of our 13 hospitals puts a new test out or changes something about the result components. We need to know about it in real time. So since 2019, about the start of the pandemic, this was a pre-pandemic project that actually turned out to be extremely useful during COVID. We've been using this tool from Clinical Architecture. So what the tool does is that every week we pull all the laboratory data from the EHR, especially the new data that's been deposited newly. We import it into this tool called SciMedical. We then undergo a week-long mapping exercise where we look at things that are unmapped, not mapped correctly, don't seem to be mapped correctly, by comparing our internal build to external standards. So the company has standards on what your lab build should look like. They also use SNOMED, they also use LOINC, they use all sorts of different external standards to make sure the LOINC codes and the laboratory build that you have all make sense. Once you make the changes, you just import the file from SciMedical right back into Epic or right back into your EHR. So you have kind of this virtual cycle that's going on. And before we had this virtual cycle going on, we found that our LOINC codes were only about 65% accurate. So you write an app to get Mass General Brigham data, you're only going to get a certain chunk of it because the accuracy is not there in the LOINC codes. And similarly, with external results from our trading partners, the harmonized mappings were only about 42% there. So a huge percentage of results weren't available to decision support, weren't available to health maintenance, weren't available for any kind of report because they weren't mapped correctly. And I don't think we're an anomaly that we didn't map things very well. I think it's just that there's so much data that a tool is actively needed. This tool has also helped us be able to, like when we bring on a new institution, we're usually just pulling data from them. We're getting lab data from, Anna Jake's Hospital or Holy Family Hospital, some regional hospital in the area, and we need to map their compendium into ours. We can do it much faster because we have an automated tool. So we've got a check mark on data now. We've done a pretty good job, I think, of getting our data ready so we can actually use it. So now what we've done is with Superset and cleaning up the data, we have these real-time pipelines that we can access our clinical data, and now we can start to do things with that data. One of the simple things when we're just sort of getting to the information stage before we start providing insight is to be able to visualize our data, just to be able to see if we're thinking about doing decision support for something like CCP or rheumatoid factor. I can look at all the ways across all our hospitals that we report CCP, understand what components I'm going to have to use for my decision support, understand which ones are flagged, which ones might not be flagged, what the common names are. You can see I have a little bit of a problem here because I have some hospitals that aren't reporting in the correct common name, so that'll be something that we'll fix with SciMedical. And then I can download this data in a single click to figure out exactly where the outliers are, where the problems are that we can fix in that sort of virtuous cycle of data. Another key dashboard for us, and I just used it today, but this was extremely helpful during, today we're giving a lecture to the residents about stop ordering so many magnesiums tomorrow. But today, in the past, in COVID times, I guess I didn't read Dr. Baer's email close enough because he had a lot in his email about supply chain. And one of the things that broke down in our supply chain very early on was heparinized syringes. We just did not have enough to keep up with the number of patients that were getting blood gases in our organization. And we started making our own heparinized syringes for a time, thinking we were going to have to use them. We didn't have to. But the key reason we didn't have to is because we had real insight into our arterial blood gases. So this is our order set utilization dashboard. I've filtered it for blood gas plus and blood gas. With a couple of clicks, I can see, okay, this is the surgeons at Mass General and the Brigham that are using most of them. It's mostly the residents we have to talk to, and it's anesthesia. And I can see that it's really this one order panel that is really driving a lot of our blood gas utilization. So we could make some changes, took off some things that were pre-checked on the order panel and reduced AVG uses by 35%, with just a couple of weeks by just changing things on a couple of order sets with very minimal care impact. And we're hopefully going to do the same thing for magnesium tomorrow, where we're going to really make the case that by changing some of these order sets, we can really order a lot less magnesium. So these sorts of utilization dashboards have ways we can tweak them so we can only see things that have big changes. One of the big changes that we noted very early on when we moved to Epic was we suddenly started seeing lots of orders for RBC folate, which is a pretty niche test. Most people obviously just need a serum or plasma folate. With our Epic order set dashboard, we were quickly able to localize this to one enterprise anemia order set that someone had snuck in without a lot of review and put RBC folate on that. We swapped it out and obviously it removed the volume entirely. But these things can get out of control very quickly, so actively managing and actively looking for send-out tests has been really important to us. So now we're at the stage where we've kind of got our information. We've got these self-service dashboards and a self-service data lake that our lab directors can use, and anyone who wants to look at laboratory utilization. Now we're going to try to start providing insight to people. And first, we're going to sort of use the traditional decision support tools. And this is an article from David Bates from almost 20 years ago now, where he talks about the 10 commandments of decision support. I think 3 important ones that always resonate with me is that little things make a big difference, simple interventions work best, and manage and maintain your knowledge-based systems. When you think about decision support, a lot of people think about an alert that pops up, and I think that's an option, and I will definitely show you some alerts and how we build them and how we use machine learning to determine the rules of how we should build them. But I think a lot of the decision support is actually, what's on the menu? What are the frequency restrictions on that test? Which order sets and panels is that test in? Do we display the cost? Are the prior results available? When you're ordering that encephalitis panel, can you see that there was an encephalitis result just a month ago that was completely normal, that would probably change your mind on whether you needed this $3,000 panel? And then how we report things. Are results falling into some others bucket where people don't see them and they're not visible on reports and not visible to a provider? So if we're going to use interactive alerting and if we're going to use machine learning to provide more interpretive guidance, we have to do it in just the cases where we think it's valuable, because these are fairly expensive resource-wise. So it's our own internal challenge to deploy our CDS tools both efficiently and only when needed. So during the COVID crisis, we took the opportunity to completely blow up our decision support infrastructure. So we had a very traditional infrastructure with a very large team. Everyone got a vote, and things took 6 months to go from concept to testing, and maybe 3 more months of testing to reality. And by that time, you've lost your window for decision support to really make an impact. So we now have a very small team of about 12 of us, and the laboratory is a big part of this enterprise decision support team. We take in the requests from across the enterprise and meet weekly and reset priorities for 2-week software sprints. So we can reshuffle the priorities. If there's a COVID vaccination, the boosters are interfering with some decision support that we have out there, that's going to take priority over something else, some smoking cessation BPA that's taking a lot of time. And you can see we have almost 50,000 alerts firing each day. So we had to build a ton of infrastructure to be able to manage these and make sure that there weren't alerts that were firing that weren't productive, and that we had a way to monitor when we put an alert out there. So this is one of very many alerts that we have in the laboratory. This is just one that we stamp this kind of alert out all the time, where we have 2 orders that have to be on the menu for some reason. We can't just delete one of the menus. There's some workflows typically that provide us the inability to remove one of the orders entirely. And so we have lots of best practice advisories like this, where we give you information about, the preferred test would be to order the SPEP panel, where we have reflexing and a diagnostic cascade. We'll do free lights, we'll do all the things you expect, rather than ordering an immunofixation up front, which is very expensive. And what we find is, most of the time for this particular alert, because we monitor it and we put it in silent mode and then we monitor it for 60 days, we were very successful. We met the threshold for kind of keeping it around at 85% of the time. Providers accept the laboratory's advice. Just one hospital saved about $40,000 per year for about 5 hours of work to build this alert. This is an alert we stamp out all the time. Order this, not that. So how do we know if it's successful? Because we have a tool. We have a tool that we didn't build for this alert. We have this tool works for all 3,200 alerts in our system, where we can look, and I'm the owner of this particular alert, so I will look at 30 days and 60 days and 90 days after it goes live, read all the comments. If this was the live dashboard, I could hover over these and read what these comments are. It actually has machine learning behind the scenes to categorize the comments. That's the colors here. But it does let us very quickly, we can read the comments very quickly and decide, are people overriding the alert for a reason that we should change, the specialty or the provider type, some of the criteria that's behind the alert. So we're always looking to make the alert better. 85% is good, but it'd be great if it didn't fire at all and people just ordered the right panel to begin with. So we're still seeing firing on this alert, and there's still some value apparently in this alert. So now talk about the paradox of choice. We're always looking for the sweet spot in lab test ordering. Reducing the number of, there's this idea that your subjective state, if you have too many choices, if you have the Blood Center of Wisconsin menu for coagulation, that has, 500 things. It's a great lab, of course, but they have 500 things you could do to work up a clotting or bleeding disorder. What you really want for a clinician is, the sweet spot. An order set with a small number of recommended tests, custom reflex orders, diagnostic cascades, making providers aware of things. This is sort of the general, how we try to think about our order sets. This didn't work at all with COVID. This was complete failure to put the tests out there and give a little information, and hopefully people will pick the right tests. The big challenge we had with COVID, like I think everyone had, a fragmented supply chain, limited supply at various times. Even today, we're still dependent on some shipments of rapid tests, it seems, week to week. Limited supply of our expanded viral panels, lots of ordering variability, lots of different ideas about when a test should be stat and when it can be routine, and different testing systems at each of our 13 hospitals. So the goal was to have a standardized approach based on infection control and clinical operations guidelines. And so our decision was, don't let the providers pick the tests anymore. And this is a template that we're using for other things besides COVID now as well, where you're going to get a COVID test, but whether you get other tests and how fast we're going to do it is going to be done by questions we're going to ask you and what we know about this patient, where this care is being delivered. So we're violating, or at least we have to keep in mind, this 8th commandment, which is you ask for additional information only when you really need it. And we felt we really needed it. We had to prioritize and triage this testing. So these are our 19 rules that we came up with to decide, who gets a rapid test, who gets a RSV, COVID, flu test, and who gets the full respiratory panel with all the viruses on it. And who just gets a routine COVID test. And routine COVID test about 8 hours, a rapid COVID test about an hour. So, if you let the ED decide who gets a routine and a rapid test, you're going to get all rapid tests, of course. And you're going to get a lot of 4-plex tests because they'll want all the viruses, and they'll even want, the full biofire panel on occasion. So by asking questions, and we always try to limit the questions, so we only have a few questions. We have to ask these questions. Just like the CDC requires you to answer some of these questions of the Mass Department of Public Health in terms of symptoms. But we would always ask the patient disposition. We would always know if this is an ED patient, so we can answer that question for them. If it's an OB patient, if it's a PEDS patient, we obviously don't have to ask those questions. But we limit questions to the bare minimum needed for report. for reporting and to run the algorithm. So when we run this algorithm, what we see is that the ping pong balls fall into very different pockets. We were able to really reduce the number of expanded rapid panels. We would only do an expanded rapid panel if you're immunocompromised or had lung disease, you're being admitted, you get a rapid panel. Similarly, if you're an inpatient with symptoms, you get a rapid panel. Otherwise, you don't. You get a routine COVID test if you're going home from the ED. You're going to get a rapid fourplex test if you're being admitted with symptoms, and so forth. So having this algorithm behind the scenes that we could tweak at an hour's notice, and we have had to tweak it, and if the Roche toolbox goes down, we gotta flip and send things to the Broad Institute across town. We can change within hours because we're not changing the actual epic order each time. We're just changing how the orders interact with our SunQuest lab system, so that the mapping there. So that mapping can be changed on the fly on a minute-to-minute basis. And it's also, it's been able to reduce the rapid testing as well, because we can push a lot of our inpatients to a more routine testing than the providers would have ordered. Another big win for us in terms of COVID was having these screens enabled us to really start collecting data in a very meaningful way in the EHR, where we can report on this data. So we made sure we had extensions for all of these order questions, so we could pull this data directly into reports, pull samples based on these responses, and then be able to take, look at the clinical course that a patient was having and compare it to all the things that were going on with their medical conditions, their lab values, and their COVID antibody testing that we would do. Some of these are clinical tests, and some of these are research tests. But having this curated, clean data enabled this early prediction of mortality, helped shape what we put on our monitoring panel for COVID for our inpatients, and informed our vaccine and booster strategies. It predicted some level of immune escape using well-characterized patient samples that we sent to MIT and the Broad Institute that had some really advanced mapping of antibody epitopes that they could use. So now to get from just checking briefly away from COVID back to the laboratory and sort of the bread and butter of how we can use this EHR data. One big area that we've historically used EHR data is for lab utilization. And so this has gotten much, much simpler now that we have dashboards. We can look at variability among providers very quickly. And as I think we have 3,000 providers just at Mass General alone, but these 25 people, A through Y on this screen, are accountable for 30% of our reference laboratory expenses. So several $1 million, these 30 people, or these 26 people. And it's the usual suspects for us are PD genetics and neurology and maybe OBGYN. So it's really a good point to understand this variability, because we know, if you have variability in healthcare, it's almost surely a sign of waste. And it's been said that geography is the #1 cause of variability. Who you see is what you get. And process improvement, if you want to think about it as a process improvement project, it's all about reducing variability. That's the anathema to a factory, is having variability. You really want to hit that target specification. So in the lingo of clinical care, that's more about having practice standards that you follow. So our utilization, we've really taken advantage of our newly available EHR data to really engage in a very different way with our providers, and just saying you're ordering too many immunotests, or you're ordering too many leptins, or whatever the test of the day that we want to ban or limit. So I'll give some examples from PD genetics, surgery, neurology. PD genetics was one that just leaps off the page, right? We have providers that are ordering $500,000 worth of reference tablet laboratory tests, and some that are ordering much less. We've basically taken the approach of let's report the data to them and encourage them to create practice standards. Having a formulary doesn't work for this group. They're all uber specialists, so they're all going to have opinions about these tests. So we really needed to work with our clinical colleagues to develop practice standards. So the first thing we did was just give them their data and just told them, there's a lot of variability. Why is this present? We would even normalize it for ICD-10 codes and normalize it for visits, and there was still a lot of variability. So what we did then is to work with them to create practice standards. This was not the sexy work of putting up a BPA or an alert and a machine learning rule, but it's really just the hard work of developing practice standards, deciding how many standard deviations does your head have to be abnormal before you do testing for Soto syndrome, and when should you do a microarray on a child with a learning development delay. So by doing this, we dropped the spend almost in half, and this has been sustainable for several years now. So about $1 million a year, it's a weekly spend of $20,000 with a lot of variability, to a lower spend with less variability. For our surgeons, one of the things that drove us crazy was that our surgeons would order tests right before surgery, pre-op labs right before surgery. On a lot of cases, and when something was abnormal, and they almost never was, but whenever they were, or there was a clotted sample, they would delay the surgery until they could get another sample. And so we showed this data to our surgeons. This is all based on using one order set, just how much variability there was. And what the issue was, it was just the labs were pre-checked on the order sets. Most of them weren't even aware that they were ordering these labs. So now we took off the pre-checks. It's now ordered on less than 3% of cases. Neurology has been one of our trickier nuts to crack. So we have, these are individual neurologists, 57. We have a very large neurology department. But they're the #1 spender right after pediatrics in our group. And so all these subspecialties have different needs, different wants, different patient types. We actually engaged an economist who works with our physicians organization to figure out what would be the expected cost based on diagnosis codes and the characteristics of the patients that they could pull out of the EHR. And we created a P for P metric for neurology, and they've actually met their metric over the last many years and have used that to really reduce the numbers of encephalitis panels, autoimmune workups they do, and really ataxia panels. And we're starting to use this approach across the board for labs, imaging, for high expense testing, to really not focus on this, not focus just on cost, but focus on expected cost. Because you really have to utilize all that data that's in the EHR that can help you, have a real conversation, not just you're ordering too much, but why are these types of patients being handled differently in different settings and by different providers. So now we've got some basic information. We've done the basic decision support. We've put up a lot of alerts. We have a pretty clean pathway to get from an idea to a decision support alert within a few weeks. We can get it built in a week. We can get it tested in 30 days of silent monitoring and then turn it on. But if we really want to provide insight to our patients and providers, we really need to start thinking, of how we can put computational techniques into what we do. So obviously, all of us put out, millions of results per year. Our core lab puts out about 12 million lab tests per year. Almost, 93% of those lab tests go out perfectly auto-filed. No one ever looks at the result. The clinicians probably don't look at 2/3 of their results. I take that from my wife, who says, there's just too many results. You look for the flags, you look for the H&L flags and everything else. You kind of just let wash over you. And the human brain is just not equipped to process high dimensional or high feature, lots of data at a time, especially when it's over time. So we can use computational techniques to cut through some of this data glut. One of the ones that we particularly use in pathology, and I think you actually might have even had a seminar about this earlier today. I saw there was a seminar on anatomic pathology and some of the techniques that are being used. They're generally using supervised machine learning. Supervised machine learning is when we look at all the features, but before we determine which biomarkers we're going to measure, we know that we are able to label the patients, disease or healthy, or this outcome or that outcome. And supervised machine learning is used for classification and prediction problems. It requires us labeled data, and then it creates a model. It looks at the biomarkers. Maybe you're measuring 10 biomarkers, and it creates a model to predict whether the patient is diseased or healthy based on that data set. Now, large data sets can improve performance in supervised machine learning, but they can be very expensive. They can be very resource intensive. If you're doing tiles of anatomic pathology images, you have to annotate every single image before your machine learning model can do anything useful with it. But most machine learning models, certainly in clinical pathology, are supervised machine learning, where we look into the chart and figure out, is this disease healthy, spurious, real, one outcome or the other, and then look at can we determine that a model that gets us there. We're starting to use unsupervised machine learning a little more, where here you don't need the data labels. So you can take a ton of data, so pour it into your unsupervised machine learning model and get insights by where clusters occur. So for these two biomarkers, there's this interesting cluster here. This cluster analysis is the basis of every shopping site you've ever been to, where it says, customers who bought this item also bought that item. And we have a project now that's going on. Can we use this to recommend laboratory tests? So we look at every test that a patient's ever had, every result the patient's ever had, and then recommend what tests that a new patient might be interested in getting based on their history. But as I said, most pathology projects are in the supervised realm, which requires labeled data. So the way supervised machine learning works is you figure, and most of the 1, 2, and 8 are things you do every day. This is not magic or rocket science or very difficult work. You're coming up with your patient panel, you measure a bunch of things on your patient panel, you go into the EHR, you determine some factor like, did this patient end up having chronic kidney disease or not? And then you clean up the data. You may have to featureize some of the data. Maybe you want to just highs and lows, or there's gradations that you need to turn into some sort of categorical feature before you run the model. Then you sort of divide up the patients into training and test sets. You use training to train your model. You pick a model, whether it's support vector machines or any kind of heuristic model. You train the data, you train the model with this data, you create a prediction algorithm, and then you take that set that you didn't use, this test data set, and test the model against it and measure how good it actually works against actual data that's never seen before. So one of our very initial forays into this was, could we use machine learning to prevent inaccurate result reporting? Can we look at, we knew we actually had a Joint Commission inspection, and they cited us for not catching spuriously elevated glucoses. And it's actually pretty hard at 2 in the morning when a glucose comes into the laboratory and most of everything autofiles except for the glucose, to figure out very quickly, is this a spurious glucose or a real glucose that might cause the patient to get insulin and to get other care. So we wanted a system to be able to figure out, should this be released to the medical record or refused and add a comment. So we turned to recursive partitioning, another thing like support vector machines or random forest, just another one of these models that can take a look at a bunch of features. So these are all the features that we looked at, and we had many more that go off the page. And then we looked in the medical record, and retrospectively, it's very easy to tell if that elevated glucose was a spurious glucose or a real glucose. And spurious glucoses happen fairly often on inpatient care because people are infusing D5W and collecting above the infusion. They don't turn off the infusion, or they collect in the same arm. So it's not uncommon. And so recursive partitioning is a nice model to use, because what it does, it basically looks at this data and tries to find the optimal decision tree to get, to separate the real and the spurious cases. So in this case, pre-intervention, our technologists could pick about 1 in 10 at a time. They would label it as, this is a spurious result. This looks wacky enough to me that I'm just going to say this is spurious, refuse the result, or at least comment on the result. However, when we put it in the model, we found that almost 90% of the time, sensitivity specificity-wise, we could tell, or the model could tell, that it is a spurious glucose. And we implemented this, and we use this every day on real patients now. We tweaked it a little bit because we didn't, you got to have pretty perfect specificity, if you're going to put something in clinical use. But we're down, the sensitivity still stayed, almost 8 times what the sensitivity is of a technologist alone looking at this. So technologists love this because it gives them a tool they can use to, really do their job better. We've also used this for wrong blood in tube. Even with all the barcodes and all the work we do around collection manager and phlebotomy teams, we still have wrong blood in tube. It's really hard to tell, for an instrument to tell if the blood in that tube does not match the patient. Delta checks don't work very well. This is the positive predictive value for a Wibit error with just individual delta checks on a chemistry panel or a CMP. They just don't, they're not useful. But with the support vector machine, which is another one of these supervised machine learning models, we can get very high positive predictive value, high enough that you could stop the test. You could say, okay, we're not going to auto-release this. We're going to have somebody look at this to make sure there's nothing funky with this sample, and make sure it's not a wrong blood and tube error before we release this to the medical record. So other areas we've used machine learning. We have a machine learning model that has helped us validate a decision support rule that we utilize for Transferrin. Transferrin is one of these tests that's occasionally useful in addition to the other parts of the ferritin, TIBC, and serum iron. But it usually isn't. So we have a validated rule, and almost 90% of the time they'll get rid of the transferrin if we give them all the reasons why they don't need this transferrin. In addition, we use machine learning to figure out what the cut point should be if we're gonna, when someone orders flow cytometry, peripheral blood flow cytometry, we get a lot of normal panels, and the flow lab was just sick of doing normal flow tests on patients that had just tiny bumps in their WBC counts or little low WBC. So we use a machine learning-based triage strategy to figure out if you don't have blasts, if you don't have a history of hematopoietic malignancy, and your neutrophil count is above 41%, there's very low chance that you need peripheral blood flow cytometry. So we're just going to do another CBC, and if that CBC is abnormal, we'll send the peripheral blood flow cytometry. Otherwise, we're not going to do it. So this has really helped, reduce the number of normal peripheral blood flow cytometry tests that we do. In addition, these alerts are wonderful. They seem wonderful when they work, but to a provider, they hate these alerts. They get these alerts all the time. Even when you're doing the most benign thing in the medical record, alerts pop up. So we actually tried to use machine learning to see what we could do to reduce alert fatigue. And one of the bigger alerts that labs put up in front of clinicians' faces is alerts because of duplicate tests. So what we wanted to see is, can we reduce the number of duplicate test alerts by looking at machine learning? Try to predict whether a clinician is likely to accept the alert, and only display alerts if it's likely to be accepted. If you pop up an alert and they dismiss it right away, and then it's a wasted alert. You didn't really accomplish anything. They still ordered the test, but you've wasted clinician time. And what we found, we could use a machine learning model looking at provider characteristics, test characteristics, time since the last duplicate test, what the result was it abnormal or not, and decide a priori whether it was worth it to display the alert. And so with the cost of a few hundred extra tests a month, we could drop the number of these duplicate test alerts by thousands per month. So there really are opportunities with this machine learning to very quickly hone in on the criteria that you need to put an alert out into the wild and have it be successful, and know that it's going to be successful, that it's going to be safe, and that it's not going to overfire. So in the last 5 to 10 minutes, I want to talk about some work that we've been doing with a group at MIT and Northwestern to predict laboratory test results. And the reason we've been doing this is because, one, with panel testing, if you can eliminate parts of the panel and not do it, if you can predict that it's always going to be normal or abnormal, you can improve utilization. Perhaps more importantly, when the actual results are discrepant from predicted results, that's often a red flag that we need to investigate and understand what's wrong with our results, or what clinical factors are causing our results to be a false positive or a false negative. And lastly, to avoid overlooked diagnoses, alert clinicians when tests are not ordered but are predicted to be abnormal. That's where we're using that unsupervised machine learning to look for clusters in the data. So ferritin prediction, we use as our first example, we use ferritin. Ferritin, of course, is a marker of iron storage. We thought it would be a relatively straightforward proof of concept because we know, it's decreased in iron deficiency, but it has this problem that it gets increased in inflammation. It can muddy the water when you're trying to look at an iron panel. So because laboratory data is so sparse in many cases, you get a few tests, you don't get all the tests, it doesn't work like a stock market ticker where you have a lot of data on every single day on every single time point. We had to utilize our friends at MIT, and this is Keith Solowitz's lab at the Computer Science and Artificial Intelligence lab, to impute missing data. So we could actually have a complete set of data for each patient, even if they were missing a lot of the data points. We can impute the data, predict it. So once we could impute the data, we found that we could actually not do the ferritin test a lot of the time. At 96%, we can actually accurately predict the ferritin without doing the test. And how is this useful? We're going to do the test anyway. We got an order for ferritin. So, but when we find out if we take patients now, a test data set of patients that are getting ferritin results, and we predict their ferritin, what we find out is that these highly discrepant results are actually very interesting. Most of these highly discrepant results are patients like case 1, where they're actually iron deficient, and we're about to tell them their actual measured ferritin is 230. This isn't iron deficiency, maybe anemia of chronic disease, maybe something else going on. But that's actually not the case. The patient has inflammatory markers based on looking at all their other laboratory tests. And this patient really should be commented on that this ferritin is not accurate. The patient's undergoing an inflammatory response. So, having an application where you put out this ferritin result is inconsistent with other testing, don't exclude a diagnosis on the basis of this ferritin alone. Also being able to avoid overlooked diagnosis, where we can see patients that, the test results indicate the possibility of iron deficiency, considering ordering ferritin if clinically indicated. So we have a project with CBC results, just looking at CBC and CMP results to put requests for orders into the medical record when we have a very high probability if there's a ferritin that's going to be abnormal and this diagnosis is not in the patient's chart already. So one simple thing you would think of relatively simple would be to predict patients that are going into acute kidney injury. And lots of people are studying acute kidney injury. And one of the reasons is because so many patients in the hospital are put into AKI every year. And you can have your plasma creatinine totally in the normal range, and a good percentage of these patients start to go into risk, injury, failure. Their creatinine baseline starts to rise without anyone noticing it. And unfortunately, right now, what we put in an advanced delta check. We use statistical modeling to figure out what the optimal cutoffs would be to let people know that this don't use the EGFR. It's not going to be accurate, and your patient is creatinine's baseline is increasing. However, this really only is alerting the clinician too late, after the patient has already met criteria for risk, injury, and failure. So what we've wanted to do, and so we were happy to see, that when we talked to our providers or surveyed our providers, they noticed the flag, and a third of these providers noticed the flag, and they stated that the flag changed the management of their patients. So they discontinued a nephrotoxin, redosed a medication, etc. But what we were really interested in is, can we do more with all that other data that's in the medical record? We were just looking at, creatinine rising baseline. But the challenge is, lab data is highly dimensional, so lots of different analytes, lots of different variables, and the methods that we have are not well adapted to laboratory data. The methods, a lot of them were created for stock market and for hedge funds to be able to, to make sense of longitudinal data. There's not as much for laboratory data, which is sampled irregularly and not sampled at random. When we get an abnormal lab, we tend to retest it more often. And the testing intervals in laboratory testing are very wide. So our current efforts are to predict things. So looking at the patient and what their hematocrit was in the past, predict their future hematocrit and put some error bounds around what we think that future hematocrit would be. So we have one student who's doing some work that's looking at, they just predict what the day 4 electrolytes. Does a patient need electrolytes on day 4 based on what their prior electrolytes would be? And so the model would predict, patient 2 needs day 4 electrolyte testing, while patient 1 may not need this testing based on the model. So where we're taking this is to start using this to predict tomorrow's creatinine. So really do something, not say you're in acute kidney injury today, but you may be in acute kidney injury tomorrow. So with narrow prediction width and high sensitivity and specificity, be able to say what tomorrow's creatinine is going to be. Then you can kind of flip things a little bit. And instead of saying they're in early kidney injury now, you'll say in 24 hours, you'll likely satisfy the criteria for AKI. So our approach, we've tried to add one more thing onto this, which is, not just might be, that's not an easy message, but just try to use some of these early biomarkers of acute kidney injury, such as NGAL, that can give you an early warning sign about acute kidney injury. We know that like procalcitonin, like all these other heavily abused tests, if we add NGAL to our EHR inpatient menu, we can guarantee ourselves hundreds of thousands of dollars of cost without a clear evidence of improved outcomes. So our hypothesis and our proposal and our trial that we're starting is that when patients meet when the algorithm predicts that this patient will meet renal failure criteria in 24 hours, add the NGAL onto that green top that we have in the lab and assess for kidney injury now. And I think this is a much more efficient way of seeing, does a new biomarker actually work, by sort of doing it in silico for a little while with an algorithm that's going to predict, for a group of patients where it's more likely to be useful than just doing it on all ICU patients or some, approach like that. So hopefully, what I've given you is a bit of a whirlwind tour of, how we're thinking about using data to provide insight. And I would say you have to start with data. It's been very important for us to really start collecting data in a very granular way in our EHR, to take the data that we do have in the EHR, make sure it's normalized, make sure it's clean so we can make sense of it. And then, just make sure that our pathologists are engaged with and educated in the capabilities of our EHR. I send people to Epic provider training all the time because I think it's really important that people understand and are able to build within the EHR. And I think laboratory data provides this key foundation for clinical care, needs to be actively managed, and not just for the lab, but for the whole entire healthcare enterprise to be successful, for its alerts, for its health maintenance, for its reporting. And I think informatics is starting to provide the tools that can really address a wide variety of these issues. So thank you very much for your attention. I really appreciate the opportunity to talk to you today. These are all the folks at MGH, the Brigham, MIT, and Digital Health that helped me with this work. I'd be happy to take any questions. I didn't leave a whole lot of time, I'm sorry, but I'd be happy to take any questions. Thank you very much.
I'm going to clap here, and I can hear through the Zoom, through everyone's mute, that there's raucous applause here. That's a presentation. We'll be waiting for other questions. I have a question of about, I guess, dimensionality in big data is my question. When you try to get multiple different data elements to predict a future event, one of the things I get concerned about is, that first of all, it can be difficult to predict with high dimensional data, and also just from my experience, data cleaning is really important with clinical data. To be able to use it for those predictions. And then I get concerned that, if I have 10 different data points I'm using to detect something, if one of those goes off because of something completely non-biological, the LOINC code, gets miscoded by somebody pressed the wrong number on the LOINC code and all of a sudden that drops out, or gets, something else gets put in its place, or we have a new machine that gets put in, then all of a sudden I'm going to have a lot of errors, not because not because the algorithm isn't working correctly, but because the data inputs are working correctly. And I'm just wondering how you think about the high dimensionality of big data and those kind of future predictions when you have a lot of data endpoints in the clinical scenario?
I mean, one approach we do take fairly often is to featureize a lot of our data to take outliers, because outliers can kill you on these models. So, to use medians, to use percentiles, to do a lot before we put it into the model. And then just to be very aware of the lack of data. And I think there have been machine learning misadventures like in the past where if you didn't have the right group of patients, you didn't have patients with asthma in your model, you would give the wrong antibiotics. One of the sort of classic machine learning problems. So I think it's important to really cover the gamut of the patients that you're really going to be taking care of. And then I think some of these techniques that people are starting to develop with imputing data can be very important to fill in the blanks, because when you have a lot of blanks, that's when the model tends to go off. So that's what we're finding when we're trying to predict who needs a test. We really have to do a lot of imputation ahead of time to build a good model, because most patients are going to be missing most tests that would be very helpful. So I think it's a really it's a challenging limitation of machine learning, but it can be dealt with. Like sort of adjusting your features, really thinking about them, not just throwing them all into a model and then trying to impute things that you don't have and filling those in.
Thank you. So another question from Patrick Matthias. Great talks. Well, thanks for all the examples. There's a lot of infrastructure built to support clinical decision support, maintenance, and monitoring. Epic offers some tools for this. Is the infrastructure that's been built because of functional limitations of the Epic tools, or because this was built prior to Epic being able to offer those tools?
A little bit of both. I mean, I think we haven't moved over to the Epic tools. We like our Tableau dashboards. We like our, being able to hook up R directly to Tableau and Clarity. I do think the tools are getting better. I think there's just so many custom tools that we need to run our lab right now that using the Epic tools puts us a little bit of a disadvantage. But I do think they're moving very fast. I've been very impressed. Like, I think the Bugsy module has made leaps and bounds, and the dashboarding that you can do in infection control, from just a year and a half ago, unbelievable. So yeah, I think Epic. We're an Epic first shop, and that's our sort of now is our mantra for sure. If it can be done in Epic, do it in Epic. This is one area where we didn't follow that early on. But I think we certainly kind of track how the tools are doing. So it's a great question. I think it is always good to go Epic first, or EHR first, because it does give you the best opportunity to add on to it and spend your time doing other things. We spend a lot of our time maintaining SuperSec, maintaining Tableau, maintaining our dashboards. And is that time well spent? Who knows?
So Nick Crum says, do you think there is more value in clinical decision support for common, easy scenarios with possibly marginal or low value, or for unusual, complex, expensive scenarios where there could be high value but a long tail to implement?
Yeah, I mean, we've focused on both. We focus a lot on the high value. We have a lot of in our molecular area, creating a lot of decision support when someone's signing up molecular studies, to really bring to make sure we don't miss a variant of significance. But I do think the biggest opportunity is really all this extra testing. It's the magnesiums, it's the calciums, it's the dross of clinical medicine that causes us to spend tens of millions of dollars on magnesium supplementation in the hospital every year for something that we're chasing an analyte that has very serum or plasma magnesium that has very little correlation with any disease. So we take both approaches. I think they're both valuable, but I think the real emphasis that we have is sort of bread and butter utilization, because I think that's the most amenable, and you have the highest volume. You can create really decision support that really works.
Thank you. I think we're at time, and I don't see any other questions on the queue. So thank you so much for your time to talk to us today. And I'm going to give you another round of applause. I'm sure that others are as well. wherever they're at. So thank you again.
Thank you, Brian. Pleasure.